Hello, my name is Allan Purdy. I would like to thank the American Headache Society for the honor of being chosen to deliver this year's Solomon Lecture. I plan to give you my observations at present about teaching headache. I have been a general neurologist with a special interest in headache for many decades. However, I do enjoy neurology and other subjects as well. I know that Dr. Solomon is a great teacher and clinician, and I hope he finds this brief overview of interest, as I hope you will as well. So thank you very much, and I will now get on with my presentation. I have no disclosures for this presentation. This is an outline of my presentation. It will be given in 3 parts. In the first part, I want to briefly revisit the update of 2018 I gave on teaching headache in San Francisco as part of the Graham Lectureship. I would like to outline to you a core concept that I've used over the past 45 years in teaching neurology and headache and tell you what might work. In part 2, I would like to talk about the importance of migraine with aura in the diagnosis of headache disorders, why neurology is so important in teaching headache, and why all cases count in teaching headache. Finally, in part 3, I will give a brief comment on the future of teaching, where it is headed now, and also try to finish on time and say thanks. This is a slide of the basic teaching concept that I've used over years, probably derived in most recent times by Sir William Osler. What's needed is an interested student and an interested teacher. The subject matter in our field is headache and neurology. The student, we hope, would be one who would have insatiable curiosity, a desire to know, far beyond what most people would want to know about a subject. This is a core concept. This is what one needs to be able to teach headache medicine and neurology as part of the process. Many other areas come into play, but this repeats itself over time. So I will leave you with this and tell you to remember at some point the student may become the teacher and vice versa, and the subject or patient could change. This is an important concept. This slide gives a little bit of advice. I frequently say in the clinic to the residents, everything is migraine unless it isn't. By this I mean that migraine is a very common primary headache disorder. We rarely see patients with tension headache in the neurology clinic or headache clinic. Migraine, on the other hand, is complex in its variables. Patients can have migraine with aura and without aura. I plan through the rest of this presentation to say a little bit about migraine with aura more than without aura. The reason being is that the aura defines the migraine as coming from the brain. Migraine has a tendency to hijack, I say, the normal pain pathways of the brain, as well as other cerebral structures. Of course, other lesions of secondary nature, such as a tumor, could also hijack similar pathways and produce symptoms which look identical to migraine. So it's important to understand this. I'm not trying to say that migraine is the only thing we have to know about, but importantly, we have to know everything we can about migraine. It's really not a lot different than saying in the movement disorder clinic, the patient has Parkinson's disease, and then trying to decide, is it really Parkinson's disease or something less or more than that diagnosis? This is a useful concept, and I hope you find it so. This slide demonstrates the importance of migraine aura in diagnosis. The graphic shows some migraine phases. Migraine aura in deep blue can follow premonitory symptoms or precede headache. Migraine aura can persist into the headache phase, or there can be a combination of phases, as seen on the slide. This is in distinction to migraine without aura. In that setting, the characteristics of the premonitory symptoms and headache are all that is available to make the diagnosis of migraine. As such, I believe migraine aura plays a pivotal role in the diagnosis of migraine in some patients. Nevertheless, neurological symptomology has to be carefully analyzed, so the history of this has to be very detailed to confirm it is consistent with a migraine aura and not some other neurological disorder. Finally, aura can occur without any headache or premonitory symptoms. This usually occurs in a group of older individuals and presents itself as a flurry of attacks recurring over time. The patient has no premonitory symptoms or headache. On asking the question if they ever had something like this in the past, and they say they did have migraine with aura or migraine, one can then ask if the current aura symptoms are the same or different. If they say they're identical, then I would suggest that they probably have late life migraine accompaniments. If they're different in any way, I think one should explore secondary etiologies, particularly cerebral vascular disease. So once again, migraine aura, being the neurological signature of migraine, plays a very important role in our understanding of this most fascinating disorder. I would recommend that you study aura in depth. It will help you understand migraine and help your patients understand it as well. On the left, on the cover of Catherine Foxall's new book, Migraine: A History, is the famous diagram of transient tachypsia by Hubert Airy, a physician in England. He presented a talk to the Royal Society of London in the late 19th century on a distinct form of transient hemianopsia. By showing the scintillating scotomata, he was able to demonstrate that his own aura was a picture of what was going on in the brain. In fact, he called it a photograph. On the right is my photograph of my aura, which I printed and actually had published many years ago. It's interesting to realize that the description of this aura was probably the first time in history of making an invisible phenomena visible in migraine. That, of course, seals the diagnosis. What makes migraine most interesting, particularly with the presence of neurological symptomology, including the aura, is that it overlaps with many other disorders in the fields of neurology and other areas. Migraine mimics, migraine variants, borderland disorders, and chameleons, or disorders that are not migraine but can present looking like migraine distinctly. The overlap of these circles, sort of a Venn diagram of some type, would suggest that they're all related. Gowers, in his famous essay, The Borderland of Epilepsy, made this quite clear about the relationship of epilepsy to other disorders. Study this slide carefully offline. There's a lot here to learn and a lot to teach about. This is the essence of what we do in our field, and this is what makes neurology and headache very interesting. So by now, I hope I've convinced you that neurology, and migraine and aura in particular, are the core things one has to know about to do headache medicine and to teach. This schematic given to me by Dr. Richard Hargrave shows the classical cortical spreading depression beginning in the occipital lobe, moving forward into the parietal and temporal lobes onto the somocystic sensory cortex, producing the amazing symptomology of migraine. Migraine really is telling us how the brain works and what it does in normal and in abnormal states. This is something to study. This is something that to date we still haven't got a definitive answer about all the mechanisms, but it is exciting. It underlies clinical and basic science. Neurology matters. Teach it, enjoy it, and make sure your students love it. I want to emphasize that all cases count in studying and teaching neurology. This young woman, a PhD candidate, presented with headaches and was sent to me to diagnose her headaches. Of course, she brought along this MR scan, which showed significant abnormalities in the form of 2 cerebellar pontine angle lesions, a lesion at the level of the medullary cervical junction outside the cord, and a parasagittal lesion as well. These actually turned out to be neurofibroma, and she was diagnosed with NF2, or neurofibromatosis 2. However, when I took her history, the most important part of headache medicine is really in the history. She gave a wonderful history of migraine with aura. Came to be that her father had NF2, and that's where she inherited that disorder. Her mother had migraine with aura, and that was the diagnosis. Throughout my career, I've taught about several types of headaches. Migraine with aura, I've mentioned in this presentation. Cluster headache is rare, but is interesting in its clinical presentation, investigation, and treatment. Dangerous headaches always worry doctors, particularly those who produce thunderclap headache. I told the residents, when you go to the emergency room, think of blood vessels. What is in the blood vessel wall, or surrounds the blood vessel, to think of the differential diagnosis of thunderclap headache. On the right is a patient who demonstrates TAC. She has a Horner syndrome on the left. She has conjunctival injection. She has tearing and nasal discharge. Her case represents one of the most interesting headache disorders I've ever seen. And for that, I will move on to the next slide. This is an MR and sagittal section of the lady in the last slide. Shows a mass in the posterior oropharynx. Initial biopsy suggested a benign adenoma, but subsequent biopsy suggested it was a lymphoma, a rare lymphoma. Her attacks were brief, lasting 5 to 10 minutes, not severe in nature, and were associated with autonomic phenomena. Preceding an attack, she get a tickle in the left oropharyngeal area. She was a most interesting case because originally I did not see her autonomic signs and symptoms. I asked her to get a photograph, and once again the photograph was helpful to make the diagnosis of attack. Study cases like hers. Look into them in detail. Have your student study them as well. These are the kind of cases that help solidify the diagnostic abilities of learners. This is what it's all about. So why does it matter if we teach correctly? Wouldn't it simply be easy just to do an MR scan and get on with it? I don't think so, and I doubt many people listening to this broadcast would. The history and the physical up till recent times have been the basis of our understanding of neurology and, of course, of headache disorders. But for the student, why does it matter? And I think it matters because everything we do, simply put, every interaction in clinical medicine is picked up by the learner. Teachers have a tremendous influence for good, and that's important. Remember, it's never a disease or a test that sticks in the learner's mind. It's a memory of being taught and how it was done in the context of a patient. This, above all, has to be remembered. I couldn't find anybody that actually said that, so this is another personal communication. So what will be the future of headache teaching? I thought it would continue along the same lines that I've outlined. But presently, in the presence of a world pandemic, we've lost a very significant part of our ability to be good diagnosticians and teachers. The basic concept survives on the right, the headache case, the teacher, and the student. There'll be more online teaching in the future, and that's probably a good thing, but we really need to engage the learner. The learner has to step up to the plate, be excited, want to learn, and to do so in conjunction with a very interested teacher. We'll need more synchronous presentations, in other words, live, so the cases can be discussed and debated. And in the end, we need more and more cases. This is the language of doctors, clinical medicine, and neurology. Thank you. So in the end, everything I've learned in clinical medicine, neurology, and headache has come from excellent teachers and clinicians. Of course, we have to learn the basics of science, research, anatomy, and all other areas of the brain. And importantly, these can be done through asynchronous lectures, online, on time, and up to date. But to really teach somebody about our field and why we do it and why we get up and do it, it's vital for the teacher to engage the student at whatever level so that they walk away with a little doubt in their mind, with a little idea that they know what's going on, with a little hope that they can solve the riddle. This is the essence of what we do. We're going to keep doing that despite all of the problems going on in the world at present. Neurology and headache are just too exciting. Thank you.